Welcome back to our Pediatric Dentist channel Tiny Teeth Talks. If you are new to this channel, subscribe the channel, and for details of this channel, visit the bio section, or you can also check out my first video. Previously, we discussed about pre-dentate period, deciduous dentition period, and mixed dentition period. Today, we will discuss permanent dentition and some self-correcting anomalies. So the entire permanent dentition is formed within the jaws after birth except for the cusp of the first molar, which are formed before birth. Some changes that can be seen in permanent dentition are horizontal overbite decreases. Horizontal overbite means overjet, the horizontal distance between the upper and lower incisors where the upper front teeth protrude forward beyond the lower front teeth, and the normal value is 1.5 to 2.5 mm. Dental arches become shorter. Vertical overbite decreases up to the age of 18 years by zero point 0.5 mm. Vertical overbite is our overbite, the vertical overlap of the upper front teeth over the lower front teeth when the jaws are closed, and the normal value is 2 to 3 mm. And overjet decreases by 0.7 mm between 12 to 20 years of age. Coming to the keys of occlusion. So the permanent dentition after establishing itself is governed by various factors. These were underlined as Andrews' 6 keys of occlusion. So Dr. Lawrence F. Andrews introduced the concept of 6 keys of normal occlusion in his landmark study published in the American Journal of Orthodontics in 1972. So Andrew in 1970 put forward these keys to occlusion after studying 120 patients with ideal occlusion. So he hypothesized that the presence of following features is necessary for an ideal occlusion, which include molar interarch relationship, mesiodistal crown angulation, labiolingual crown inclination, absence of rotation, tight contacts, curve spe. Let's understand each one by one, and you will also learn in detail in prosthodontics and orthodontics, but here I will cover only that much portion which needed in pediatric dentistry. So first is molar interarch relationship. So the distal surface of the distobuccal cusp of the upper first permanent molar made contact and occluded with the mesial surface of the mesiobuccal cusp of the lower second molar, and the mesiodistal cusp of the upper first permanent molar fell within the groove between the mesial and the middle cusp of the lower first permanent. A canine and premolars enjoyed a cusp embrasure relationship buccally and a cusp fossa relationship lingually. The second is mesiodistal crown angulation. The term crown angulation refers to the angulation of the tip of the long axis of the crown, not the angulation of the long axis of the entire tooth. The gingival portion of the long axis of each crown was distal to the incisal portion, varying with the individual tooth type. The long axis of the crown for all teeth except molars is judged to be the mid-developmental reach, which is the most prominent and centermost vertical portion of the labial or buccal surface of the crown. The long axis of the molar crown is identified by the dominant vertical groove on the buccal surface of the crown. In this picture, there is inappropriate crown angulation, and in this picture, there is appropriate crown angulation. So, due to the inappropriate crown angulation, there is an inappropriate alignment of the teeth, and there is a proper alignment in the teeth due to the proper mesiodistal crown angulation. Coming to the crown inclination. So crown inclination refers to the labiolingual or buccolingual inclination of the long axis of the crown, not to the inclination of the long axis of the entire tooth. Crown inclination is determined by the resulting angle between a line 90 degree to the occlusal plane and a line tangent to the middle of the labial or buccal clinical crown. If the cervical area of the crown is lingually placed, then it is called positive crown inclination, and if it is more of a buccally, then it is called negative crown inclination. In maxillary incisors, there is a positive crown inclination, mandibular incisors negative crown inclination, and posteriors negative crown inclination. In maxillary incisors, The gingival portion of the crown is positioned lingually while the incisal edge is more labially. This forward tilt helps maintain proper overjet and aesthetics. In mandibular incisors, the gingival portion of the crown is positioned labially and in incisal edge is more lingually. So this backward tilt contributes to the occlusal stability. And in posterior teeth, the gingival portion of the crown is positioned buccally while the occlusal surface is more lingual. This ensures proper interdigitation and functional occlusion. Coming to the absence of rotation. Rotated teeth will occupy more space, hence normal occlusion should be free from rotation. Rotated molars and premolars occupied more space in the dental arch than normal, and rotated incisors may occupy less space than those correctly aligned, and rotated canines adversely affect aesthetics and may lead to occlusal interference. Tight contacts. Permanent dentition should have a close contact to optimize space. Persons who have genuine tooth size discrepancies pose spatial problems, but in the absence of such abnormalities, tight contact should exist. Curve of spee. The curve of spee is natural curvature of the occlusal surface of the teeth when viewed from the side. It begins with the canine and follow the buccal cusp of the posterior teeth extending to the terminal molar. This curve plays a crucial role in occlusal function, mastication efficiency, and orthodontic treatment planning. There is a clinical significance of this. So exaggerated curve of spee often associated with the deep bite requiring orthodontic leveling. Flattened curve of spee may indicate occlusal instability or improper force distribution. Normally, occlusal plane should be flat with the curve of spee not exceeding 1.5 mm. So there is a natural tendency of curve of spee to deepen within the time. For the lower jaw's growth downward and forward sometimes is faster and continuous longer than that of the upper jaw, and these cause the lower anterior teeth, which are confined by the upper anterior teeth and lips, to be forced back and up, resulting in crowded lower anterior teeth and deeper overbite and deeper curve of spee. So here is a deep curve of spee result in a more confined area for upper teeth, creating spillage of the upper teeth progressively mesially and distally. Then this is a flat plane of occlusion. Then there is a reverse curve of spee. Coming to the self-correcting anomalies. So these anomalies arise in the child developed dentition during the period of transition from pre-dented period to the permanent dentition period and get corrected on their own without any dental treatment. So in pre-dented period, three anomalies which is corrected by following mechanism. So first is a retrognathic mandible, which is corrected by the differential and forward growth of the mandible. Anterior open bite, we know that during the predentate period only place which is in the contact is at the molar area, which is corrected by eruption of primary incisors. Infantile swallow pattern, and due to this anterior open bite there is a creation of infantile swallow pattern, which is also corrected by eruption of the teeth and change of diet from liquid to solid food. Now during deciduous dentition period, there is an anterior open bite which is due to the mandible position initially more posteriorly, leading to the increased vertical overlap, plus primary incisor erupt before molars, and there is absence of fully erupted primary molars, which is corrected when the adhesion of the incisal edges of the incisor occurs, when the permanent molars erupt, when the mandible grows forward and downward. Then physiologic spaces. We all know that space dentition is necessary so that when permanent incisor erupt they use the spaces. Primate space, we all know that it is a space present between the maxillary lateral incisor and the canine and mandibular canine and first molar, which is occupied by the early mesial shift, so corrected when there is a early mesial shift. Then flush terminal plane, when there is a early mesial shift and late mesial shift, it will be corrected. Then during mixed dentition there is an anterior open bite due to the vertical maxillary access or downward rotation of mandible and increased lower facial height, so which is corrected by slight supra eruption of the permanent molars and premature contact of pads of tissues. Mandibular anterior crowding, which is corrected by canine width gets increased, and with the muscular forces from lip and tongue, there will be labial movement of the incisor get inclined. Ugly duckling stages. We all know that during eruption of the maxillary canine, there is a ugly duckling stage, but after the eruption of the maxillary canine, it corrected by itself. And on molar relation during late mesial shift by using leeway space of nans. So these are the references. If you want this as a PDF or any other PDF, just like, subscribe, and comment your email ID with the topic. I'll share you the PDF. New videos on Sunday. We also put nowadays image based MCQs in pediatric dentistry in our shorts, and we'll put lots of other type of MCQs related to pediatric dentistry. So press the bell icon for every update. Like, share, and subscribe. Thank you.